Good morning, everyone. So happy to see that you are surviving until the last day. If you didn't, I would feel responsible, not more than FAD, but at least as much as for the acute cause of death. I don't know what happened to you, but I'm always excited many months before when you set to be somewhere, you attend a conference, you plan to teach in a meeting, and then when it comes to those days, you have many other things that are there that wait to be done. So I'm sure that you had planned to be here, and then many things are competing at home, at work, and so on. So thank you for being here and for being early. I think that teaching and learning is a sort of teamwork where you have to have collaboration on both sides. Now, we start looking at the application of what we have learned. Not saying that the previous 2 days were not practical. In the tutorial and also in part of the content delivered through the presentation, we tried to show what's the implementation side of EBM. But today we'll go even more into detail. You will still learning about diagnosis in the next lecture. Diagnosis is a pretty complicated matter, and the colleague Longenecker will guide you through a pretty complex study design in a usually brilliant way. But besides learning about diagnosis, we have the component with us. Now, we have to think again how we use this evidence in making clinical decision. And one of the tools that we have available for clinical decision are guidelines or practical recommendation. So we'll spend some time in starting this day looking into the components of a guideline development process. You have seen this pyramid already, and I think I showed you that this was really partly self-serving. Initially were 4 levels, and then they became 6 when Brian Haynes started the ACP Journal Club and Plus. Because indeed, these one here are studies, original studies or studies re-abstracted for perusal in a simplified way. And these here are systematic reviews. In the original pyramid, from systematic reviews, we were going directly to summaries, to online textbook, point-of-care resources. Now we have modified the pyramid to indicate down here studies and systematic reviews as they are in one single level. Up here we continue to have summaries, but in between we have added guidelines, systematically derived recommendation. So instead of giving you the theory first and then going down to an example, I'll continue to follow the McMaster way, and we start from an example. These are guidelines on breast cancer screening developed 2 years ago in Saudi Arabia by a collaboration, as a fruit of a collaboration between the EBH Center in Saudi Arabia and McMaster. And they ended in giving 5 recommendations where they suggest screening with mammography in different ages, so 40-49 suggestion to screen, 50-69 suggestion to screen, no screen 70-74, suggestion not to use the self-breast examination as a reliable clinical intervention, and to use instead the professional, and not to use the professional-based clinical exam as the only way to screen. And that's okay. We read the guideline and we know what to do. The problem is both issuing the recommendation and interpreting the recommendation. And to get there, it's important to distinguish the probability of something and the confidence in something. So if we think of an outcome, like breast cancer, and if we think of the outcome of the screening as breast cancer prevention, so our outcome is now breast cancer prevention, we can estimate, looking in the literature, what's the likelihood of preventing cancer, but we also can have a likelihood of preventing cancer of 10%, 50%, 80%, whatever you want, and we may be more or less confident in that prediction. If you think of meteorology, well, I mean, here in Kuwait, very likely it's not difficult to make weather forecast. But in Canada and in Italy, more or less it's the same. I mean, you are interested to know if it rains or it's sunny, mostly because you decide to do something or something else, but you don't need to think of your clothes. In Canada, you need to look at the weather forecast every morning, because it might be +3 or it might be -30, and you can't get out with the same dressing depending on the temperature, and it may change quickly. So weather forecast is a big thing in many countries, including North America. And you can say that there is a 20% chance of rain, because that's what the forecasting system tells. And you may say that you are 10% sure that you know if it will rain or not. Or you may be 80% sure that the chance of rain is 20. The chance is still 20. Your system predicts 20% chance of rain. But you may be more or less sure, depending on the data used for the prediction, that you know what you are speaking of or not. Now, if you translate that to medicine, it's more or less the same, just it's more difficult to accept. So if you go to your patient and you say, I think that this pill will reduce by 20% your risk of stroke, and very likely there is a 10% chance, I know what I'm saying, well, your patient very likely will kindly thank you and then go to another doctor saying, well, there is no one here that have more than 10% confidence on what is he saying, but it's exactly the same. So when we give a recommendation, we attach a strength. So we can give a strong recommendation. If you use the GRADE system, we call the recommendation strong or conditional. We don't say anymore weak. Weak doesn't sound good. It's not weak, it's conditional. Strong means we have high confidence that we have to use this intervention, or we don't need to use this intervention. Weak means we suggest using this intervention in some situation, maybe not in others. And of course the recommendation can be for, suggestion to use, or against, suggestion not to use. Now, how you do interpret a conditional or weak recommendation? I start from the conditional because it's more complicated. The strong is easier to understand. So a conditional recommendation for clinician means to be prepared to help patient to make a decision, because the decision to use or not that intervention may depend on their own values and preferences. There is no clear signal to go that way. It's not a 15% benefit and we are sure of the benefit, and there are no side effects. When we say sure of the benefit, at the recommendation level, it's not anymore the single odd ratio, risk ratio, hazard ratio for the positive effect. It's the balance of everything. It's the balance of positive and negative. So our confidence has to be high in the overall balance of all the effect. So in the conditional, we suggest doctors to be ready to incorporate components, values, preferences, cost that can make a difference in the decision. And then there are similar interpretation for policymaker or for patients. For strong recommendation instead, the concept is most patients should receive the recommended course of action. you don't expect to spend a lot of time discussing. It's pretty obvious. Everyone having had a stroke will be on aspirin. Now, what I'm trying to progressively make clear is that it's a two-step process. The first step is to appraise the body of evidence. And the second step is to incorporate other dimensions. The appraisal for a decision, and I think you have been exposed to this, well, for sure by life, but also by the previous 2 days of course, is that we appraise the body of evidence, not one single study, not one single outcome. To make a proper decision, we need to have a broad understanding of that intervention coming from different studies and consider at the same time pro and cons, benefit and harms. So a body of evidence. And then we incorporate other dimensions. For the body of evidence, we are quite ahead. We know that we have to appraise studies, summarize studies, balance the outcomes. For the incorporation or other dimension, cost, preferences, I think I started there. The very first day, I showed you the paradigm of Alba Di Censo, 4 components of decision-making, and I recall that you picked all the 4. So we are speaking the same language. Now let's see how those same components should be incorporated in guidelines. And if you have access to good guidelines, and we will have a tutorial today where you will be called to distinguish a good and a bad guideline, you would expect that most of this job has been done already, including cost, preferences, feasibility, acceptability, and so on. Now, rating the evidence is a critical step, require the expertise you are learning these days. There are many different approaches to do this in guidelines. I will speak to you of the GRADE approach because that's the one I know and I use, but NICE, SIGN, the American College of Rheumatology, they have different grading system. The most important concept is the reliability and transparency of the process, and also the breadth in including all the needed components. I declared my bias toward GRADE. That's what I contribute to. I'm a member of the working group, and I'm the lead of the prognosis and rare disease working group in GRADE. But I'm not the only one using grades. There are over 80 major organizations, including the WHO, Cochrane, SIGN in Scotland. They abandoned their way and adopted grade, NICE in UK, and so on. It's becoming a common language. Now, this is a quick summary of what we have learned in terms of critical appraisal in the perspective of using these in guidelines. So we value most RCTs when it comes to treatment, so the chance component. We consider also observational studies, of course. When it comes to treatment, they start a bit lower, but when it comes, for example, to baseline risk or diagnosis, they may start high independently of randomization. Depends on the indication. But for treatment, we consider randomized and observational different level. Then we consider 5 factors that can lower the quality of the evidence. The first factor are all the limitation in the study design, all what goes into the risk of bias. So you have been exposed quite a while these 2 days about what makes bias into publication. Then we look at inconsistency or heterogeneity. We will expand a bit more on this, how to value if in the body of evidence the studies are going all in the same direction. You have made already some judgment calls saying, oh, they are all on one side. Fine, that's the way to start. There are other aspects that you look at when you look at heterogeneity. Indirectness, are the population, the time gonna treat, and the population in the study similar? We have done this in all the exercise. Imprecision, is the confidence interval too wide or narrow enough for our decision? We'll come back on this. Publication bias, we have seen in the systematic review exercise that we are worried that negative small studies may not be published, and we can have a biased, distorted summary of the evidence. Then there are also mechanisms to increase the quality, particularly in observational studies, when we are more confident. For example, when there is a large effect. Everyone gets the treatment, survive. Everyone does not get the treatment, dies. Well, even if it's not a randomized study, if there is a large difference, and there is a large difference on an important outcome, usually survival is considered pretty important, we are, even if the observation comes from a non-randomized study, we may value that more. Or, yes, the study is not randomized, but if there is confounding, it goes against what we observe. So confounding is playing in favor. Even if smoke and coffee are mixed up, both seems to improve survival. So what's the problem? Even confounding would make the effect, removing confounding would make the effect even bigger. It's not very common to have no plausible confounding against, but if it happens, we increase our confidence. Or there is a dose-response effect. We are not sure if a beta blocker affect the heart rate. It was never showed in a randomized trial, but if I give 1, 2, 5 milligram of, say, carvedilol, I see a progressive reduction in the heart rate. May not be carvedilol, but if that's the only thing I change, and I go up and down with the dose and the heart rate goes up and down, I might not know if that improves or decreases mortality, but I'm pretty sure of the effect on the heart rate. So when I see a dose response, I'm always more convinced. Now, all of these has to be considered in appraising the quality of evidence for a recommendation. And it ends into the evidence profile. We have seen yesterday, I'm not sure if everyone looked at it, but there was an evidence profile in the systematic review on antibiotic for dental extraction. And the 5 domains are in this portion of the evidence profile. You cannot read here, but these would be the risk of bias, imprecision, inconsistency, applicability, directness, and publication bias. For each of the outcome, you have the question up here, you have the outcome on the rows, and then you have, for each body of evidence, not individual study, different outcomes for the same body of evidence, you have the appraisal of the risk of bias. And you make a final judgment here, and you say the quality of evidence is high, moderate, low, or very low. And this judgment is the sum of the individual component appraisal. And if there are no risk of bias, good. If there is risk of bias, you find down here in the notes what the problem was with that study. So if you have some background knowledge from a course like this, and you read a Cochrane review, and you go directly to see if there's an evidence profile, from that table you can get almost what you need to implement the evidence summarized in that Cochrane. You look at what the questions are, and there are usually many, what the outcome considered are, how the risk of bias was appraised, what's the overall confidence. If you disagree on some of those, or say it says, oh, this doesn't apply to US because the study was done in Kuwait, well, of course, you change that rating because for you it counts. So there might be value in going into the notes, but then you have the general appraisal, you have the estimates here, and from here on, I'll tell you in the next part of the talk how we go in transforming the evidence and the confidence we have in the evidence into recommendation. Before going there, a couple of other concepts. So we say quality of evidence or confidence in the balance of risk and benefit as synonyms. Doesn't matter. It's not that we like the quality of evidence like you may like the quality of a rug or the quality of of food. It's not just for the pleasure of quality. Quality means confidence. The higher the quality, the more confident we are that the effect of the intervention goes in one direction. And another graphical representation, here we have again the randomized trial observational, starting high, starting low. Here we have all the components of the risk of bias. What happened? You can start high with randomized evidence and you can go down if you find bias, or you can start low with a randomized and you can go even lower if it's a randomized, badly done study, or if it's particularly well done and there is a large effect, dose gradient and so on, you may start low and ending high. So the concept is in going from here to here, from the evidence to the recommendation, in going from the study design, to the quality, there are considerations that can bring it up or down. The old school was saying randomized trial, high quality, case control, low quality, period. We do something more complex. We consider if that randomized apply, if that randomized is well done, if the observational evidence is really that bad or was the only thing possible there and show a big effect, so we consider that for strong recommendation. And we try to do that in a transparent way, reporting it in the evidence profile. I don't want to spend more time on the risk of bias. I think we have given many views from different perspectives, but I'd like to spend more time on imprecision and inconsistency. So usually you assess both precision and consistency on a forest plot using the confidence interval, and the basic concept we have taken is consistency is being the average effect more or less going in the same direction. One alternative reasoning is most of the average effect fall onto the confidence interval of the other study, which means most of the confidence interval overlap with each other, which would mean one study could have gotten the result from the other and vice versa. They would still fall in the confidence interval. So the concept about heterogeneity is same direction easy. There is heterogeneity. And overlap of the confidence interval. If you have two studies, both positive, but very far apart, and their confidence interval do not overlap, you still have heterogeneity. There is an effect, but maybe small or large. And the two studies seem to say two different things. There is no overlap in their confidence interval. Precision is the width of the confidence interval. And is not, again, a matter of I like the color of the rug. Is the rug proper for the room? You may have a beautiful rug, but it's too big, doesn't fit. And you can't cut it or you can't fold it on the walls. It's beautiful, but either you change house or you go for another rug. It doesn't fit in your room. It's not just how large or how small. It's how that width, how that variability compare with the decision I have to make. Now, I want you to do an exercise to see if this concept is clear to you. So be ready to raise your hand. You can use the right hand or the left hand, I don't care, but you have to use one. Or you can raise a foot, doesn't matter, but say something. So this is a standard forest plot. It's the backbone of a forest plot. This is the identity line. Negative sign, no good. Positive sign, good. Now, I will show you a few effect size, and I want you to tell me which one is significant, which one is most precise, and which one is the one you choose for your patient or for yourself. Okay, let's try. This one and this one. Which one is significant? Red? Who says red? Red. Who says blue? No one. Good. Which one is most precise? Red? Okay. Anyone says blue? No. So many of you are right, the other are sleeping because there are some not raising hands. Which one you choose? Red or blue? Sorry? Based on what? Good. Well, since we did not speak of cost, and we assume these two interventions cost the same and have no adverse effect, and what I'm showing you is not let's assume that this is the overall balance benefit. It's not preventing stroke or causing bleed. This is a sort of a sum of all of the effect. But the question is very appropriate. Based on what? Assuming this is what counts, then you'll choose red, correct? Okay, good. This was easy. Now, let's make another example. This one and this one. Which one is significant? Red? There's one person saying that red is significant. Blue? 1. All the others have no opinion? Both. Okay, so both are significant. Everyone agrees? Good. Which is most precise? Red? No. Blue? Blue. Excellent. Which one you choose? Red or blue? Well, I told you this is the overall effect. This is negative, this is positive. So you can think of whatever you want. If you prefer, let's consider a medication. From now on, we have other questions for you. From now on, we consider stroke prevention, and we have a new medication that has no side effect, doesn't cause bleeding, it prevents stroke. Sometimes it causes stroke, but the only effect of the medication is increasing or decreasing the chance of stroke. It costs like standard treatment. So we have no cost involved. We will factor all that in. For now, let's look just at the effect side. So in this case, they are both significant. Red is most precise, but which one you choose? Red or blue? Red? Well, you choose red because blue is significant, is precise, but causes only harm, goes in the wrong direction. So you want this one, which is significant, is less precise, but goes in the right direction. Clear? Okay. I understand that you want to say, oh, but which other outcome, is there cost involved? We can do the exercise that way, but we may take the entire day. So let's make it simple. We have just one main effect, and the balance goes in that direction. Let's consider this one. So this is the red, and this is the blue. Which one is significant? Both. Correct. Which one is most precise? Blue. Which one you choose? So someone says red. Who says red? You. And who says blue? Why you would choose blue? Because the confidence interval is smaller? Yeah, it is smaller. But if you consider that this is the effect, and the more you are in this direction, the better. Okay, here you may be with the red. You can be anywhere from here to here. So say the risk reduction goes from 30% to 90%. You don't know where it is between 30 and 90, but it's anyways above this one. This one can be from 15 to 30. So this is most precise, but is worse than this one. Because in this one, wherever you fall better than here. Correct? So they are both significant. B is most precise, but A is better because the effect is higher. Now, this one and this one, which is, and this one, 3. Forgot the poor green guy. So which one is significant? All of them. Which is most precise? Blue. Now you know. Blue is almost always most precise. And which one is your choice? Red. And in this case, it's not because of the lower boundary. The lower boundary is at the same point. So whatever you choose, the minimum effect you get is this one here. But with red, you may be lucky and you may have a broader effect. So sometimes precision is not really good. In this case, precision is bad because here is imprecise, but can be more effective. You see that we are using a sort of a second line. So this is the line of significance. But in this case, we are comparing with the line that sits here, which is the minimum effect. Now, let's assume that we set a minimum effect. We are not interested in medication that, yes, they do something, but we don't want to say that every, I don't know, is a painkiller, or yeah, let's make the example of the painkiller. If the effect on pain is, say, this small, and the medication gives you nausea with certainty, you may say, if the effect on pain is big, I can tolerate some nausea. But if the effect on pain is small, and I get both pain and nausea, I don't want to get that medication. So you set a threshold, and you say, anything that works less than this, I don't care. If the stroke reduction is less than 5%, I don't bother taking the medication. I'm interested in a reduction of 30% or more. So now we have the significant line, and we have a decisional line. And now you have the red, and you have the blue. And the green, poor green. Okay. So which one is significant? All. They are all on one side of the identity line. Which is most precise? Blue. And which one is your choice now? Blue. Because even if you may be worse than here, and these might all be significant, blue doesn't touch the decision line. Good. This one and this one. Which one is significant? Blue. And which one is most precise? Blue. Now, let's assume that you have no other choice. This is a cancer patient, and you are comparing two treatments. One is blue, and one is red, and this is survival, increasing survival of 3 months, and some severe side effect, neuropathy, and I don't know, nausea. So this is the minimal important effect. Which one you choose? Red is not significant, is not precise, but there is some chance it does something. Here, there is no chance. Then you can discuss. The payer may not want to pay for this one because it's not statistically significant. But you may well make the case that for a patient that wants some attempt to be treated, this is, if there is something to do, is this one. This one here doesn't matter. Now we have this one, and this one. Which one is significant? All. Which one is most precise? Blue. And which one you choose? Red, again, is the less precise, but does something. We don't know if it's just over there, or if it's out of the screen, close to that wall. No, the other wall, but still does something. Okay, so confidence interval, you judge against a threshold, and you judge considering the direction. Any question on this one? I don't have any more exercise. Was this helpful to try to clarify the concept? Okay, good. Now, publication bias, you have seen, you plot the effect size against the size of the study. You would expect random distribution in a sort of funnel, in a triangle. If there are empty areas, you may have problems there. How you judge directness? You compare the PICO of the systematic review, the PICO of the body of evidence, with the PICO of your clinical setting. And they can be equal or different for any of the components. So in this case, the intervention is the same, the outcome is the same, the comparator is the same, but the population is different. It does not apply because the evidence comes from orals and I'm a pediatrician. Or you might have the intervention offside. I'm interested in non-opiate, short-acting opiates, and I have good evidence, but it's on long-acting opiates. So yes, it's on opiates, it's the same medication, it's the only evidence I have, but the intervention is not exactly the same. Or was given sub-Q and I'm planning to use an oral treatment, or some variation between the intervention that you have evidence on and the one you plan to do. The outcome, I'm interested in prevention of stroke at 5 years, and I only have evidence on prevention at 6 months. It may correlate, it may not, and so on. The ideal case is when the two population, the one in the evidence and the one in your clinic, are completely overlapping. Now, how all of this comes together? Again, in the forest plot, ideally, you have all of this balanced, and you have the judgment of low, high, or very, very low, low, moderate, or high quality evidence. And you can use that for different questions, so screening at 70 here, self-examination, and so on. But between the evidence and the recommendation, there is much more. We have already said that the old school was RCT, high level, strong recommendation, observational, low level, weak or conditional recommendation. But it's not only a matter of considering different aspects and having crossing lines. It's also a matter of considering resource use, balancing all benefits, harm, burden of care, and patient preferences and values. So when you go to make your judgment, you consider the outcomes, the positive and negative, the importance of that outcome. If you are balancing strokes and GI bleeds, you may say that I might prefer to have a TIA than a GI bleed requiring transfusion and risk of death, or that instead I may value the same stroke and intracerebral hemorrhage, or just because I saw anyone in my family dying of stroke, I'm ready even to bleed in the brain, but I don't want to see stroke anymore. There are individual components in deciding how the outcome compare for importance, and sometimes it's very difficult to trade off side effects, say clearing pain, but being drowsy all day. Someone says, I don't care, I don't want to have pain, and I'm happy to sleep from now to death, and someone else says, no, I still have things to do, and I'll take on some pain, but I want to be able to think and do. And then there is also cost. There might be a treatment with lower cost and better cost. Now, if the outcome are better, the importance is higher, and the cost is lower, all goes in one direction. But some other time, you may have instead different cases where outcome would be better, they are important, but they cost much more, and then the balance can move depending on how you factor all of these in. And it's not only cost, you may have fewer symptoms, better quality of life, lower risk of complication, use of resources, more adverse effect. You have to come up with a balance. How you get there in a transparent way. And the transparent way means that wherever the recommendation is conditional, and you have to take into account patient preferences and value, they may be different for 2 consecutive patients that gets into your clinic. So, of course, there's no one that can do your job. You are in clinic, you do the job. But if you are using a recommendation, you may want to know what made the difference. So if it's a weak or conditional recommendation, you may want to know conditional on what. Is mostly cost or is mostly side effect? And then you would know, I recommend this in patients who can pay for the medication, or I recommend this in patients that accept this risk of side effect. And you create your framework for where to use, where to not. GRADE as a process that is very formal. You can't read, but it doesn't matter. If you will ever sit on a GRADE panel, or if you look at a GRADE guideline and you look in the appendices, you'll always find this table. I'll have later on more details, still not readable, but a bit bigger, detailed images. But the concept is that after you have assessed the evidence, and the evidence is up here, is the green part. So you review the evidence, you around the table in the panel, you conclude that there is high quality evidence for benefit being more than side effect. Good. Then you say, and this is this level here. So you have appraised the evidence, the problem is important, benefit and harm you have considered, you have balanced, you are confident, so there is a 10% chance of rain, I'm 80% confident that it will rain, so I know what we are talking about, but still, that's not all. Then you start incorporating values. And the typical question when it comes to values is, do you expect different patients putting different values to the side effect and beneficial effect that we have considered? Resources, is the intervention expensive? Equity, if we introduce this intervention, are we creating inequity in the population we treat? For example, is an intervention that requires to go in a third-level center. So the one far, they may pay much more. And so it's not that you do not recommend, but you put notes where you say, if we are going to recommend this intervention and we want everyone to have the same chances, we should consider that there is need of moving patient around. So you then need to, I don't know how it works in Kuwait, maybe it's small enough that moving patient around is possible, but in places like Canada, you may need to factor in cost of moving patient with helicopters from one center to another to access some treatment, if that's considered what the healthcare wants to provide. Acceptability. The treatment may be beautiful, exceptionally effective, no side effect, it doesn't cost a lot, does not create equity, but it requires the patient to stay head down, feet up for 18 hours. I'm just making it up. And you may say, well, all good, but I can't see my patient staying feet up and head down for 18 hours every other day. No way. It's a good idea, but it's useless for us to recommend. They won't do it. Now, this is an extreme example, but you may have a sub-Q injection, insulin, better than an oral, but you know that people prefer to get a pill. So in recommending, you take that into account. Feasibility is a simple intervention, cognitive behavioral therapy. Unfortunately, you have to have the psychologist on site. If he's not there, you can't use it. So it's not feasible. We can't move a new CT device, buy a new CT for each hospital where we want to have a specific diagnostic, and so on. After you have considered all of these, and all of this is answered by the panel, they tick a box on yes, no, we don't know, there is no evidence. They put notes about why they ended to recommend something or the opposite, or make a judgment or another judgment, and this goes down on all the domains. So all the one I briefly discussed, cost, feasibility, acceptability, equity, the panel will consider if there is evidence to support this component, and if there is no evidence, they will come up with why they have decided there is no impact on equity, or why they think, say the intervention was never used for a disease, is, I don't know, use of prednisone for a specific kind of pain, and one may say, oh, was never used before, but prednisone is used widely in rheumatoid arthritis and lupus, is used as local injection in many neuropathies, so there is no reason to imagine that these patients will not get the same intervention that other patients in other disease accept very willingly. So whatever reasoning is done is transparently reported in the table. And then when you are at the end of this and you have answered all the questions, it comes almost automatic to look at where the checkbox are. If they are all on one side, you end usually with a strong against, all on the other side, strong in favor, and if they are sparse, you end in no recommendation or weak against, weak for. So the extremes are strong in for or against, conditional in conditional in favor or against, and in the middle we cannot really tell anything. This is the general process. Does it make sense? Would you be more ready to use to implement a recommendation if you, well, if it seems good to you, if it does make sense, very likely you don't need to go back. Is something obvious, is also recommended in a guideline, you'll do it. But if the recommendation is not you would have expected, or if you start trying to apply that recommendation, but you can't get that intervention in your hospital, you can't get patient to do it, would you think would be good to be able to go back and check what the reasoning was? We think it is, and that's why because it takes time to guide a panel through all these steps. And it takes time to write it down everything and publish it as appendix to the recommendation. But if you look at grade recommendation, all of this is available. Now, to conclude, I want to show you 5 cases where you end in giving strong recommendation even if the quality of evidence is low. Because there are cases like this. For example, when there is a life-threatening situation, or there is uncertainty in benefit, but the harm is certain. You don't need very high quality evidence. If there is a reasonable clear that the medication doesn't work, even it's not clear if it works, but it certainly does harm, well, you may not want to use it. And you say, well, that's not very common. You'll see, it's pretty common. Or they are equivalent, but one is less risky or less costly. Or there is a likely rare harm, but is very, very catastrophic. In this situation, even if the evidence is low, you can issue a strong recommendation, which is common sense. GRADE is the only guideline issuing system where there are situations like this described. But if you look in UpToDate, and I know that you use UpToDate, and you check the endocrinology chapter, there are 113 recommendations that are strong recommendations based on low quality evidence. Because in endocrinology, there are not many randomized trials, there are not many good, well-done studies, but there are many obvious effects. There are not a lot of studies showing that growth hormone normalize the growth of a child with hypoproduction. But if you don't give it, they stay small. If you give it, they grow normal. So it might not work, but you don't want to be the one responsible for a case of nanism, so you give it. Because the effect is very, very large, and the side effect is very, very minimal. So there are many. I don't want you to read, but these slides will be available to you, and if you enlarge it in your laptop, you can read it. And these are the five cases. So just to give you one, when there was the avian flu, the WHO issued a recommendation saying we don't have a lot of evidence that oseltamivir will work, but it does something in the standard flu, and since the aviary flu was deadly in many cases, the recommendation was use it. When you have a diagnosis, use it. It may not work, but it's for sure worth trying. Side effects are not really terrible, it's just expensive. Or instead, do we use in idiopathic pulmonary fibrosis azathioprine? There is not a lot of evidence that it works, but we know from other diseases that for sure it has a high impact in terms of harms. So idiopathic pulmonary fibrosis is not good to have, but it's not killing you the following week. And yes, you can't really run to answer the phone when it's advanced, but you can still somehow have your cognitive function well and preserved. If you die because of a side effect of azathioprine, not knowing if that helps, is that a good deal? Well, it is not. And so the recommendation was strong against. This is my final slides. And I don't think I need to read the take-home messages. I hope that you start seeing how it all comes together. And as I anticipated you, you still have to learn about how to incorporate properly diagnostic evidence, and that's what you'll do in the next hour, what we'll do together in the next hour with Longenecker. But even that piece will be brought in a general reasoning of this kind, which, if you think of, is very, very similar to clinical decision-making. So I think we did well in changing the pyramid and in fitting guidelines between systematic review and the textbooks. Because you don't find, well, I have to correct myself. Both Dynamed and UpToDate, they start now to present evidence profiles like the one that GRADE guidelines do. But for sure, that middle layer of guidelines, you may use UpToDate or Dynamed for diseases that you don't see every day, where you don't do a lot of fine-tuning, and particularly where you are not the last one in the chain. You can always refer difficult cases to the specialist, but when you are the specialist, and there's no one else back there, and you have to make the decision, and that's your field, you'd better use guidelines, and you go in looking at what are all the components of the decision. And I hope that I have explained you that there are many places where, if the guideline is well done, which we will assess later on, you can find what you need. Thank you.